एवरीवन, आज हम लोग पढ़ेंगे बैक्टीरियल एंड वायरल मेनिंजाइटिस के बारे में और साथ में पैरासिटिक इन्फेक्शन ऑफ CNS के बारे में। सो बैक्टीरियल मेनिंजाइटिस पहले तो है क्या? इट इज़ द एक्यूट प्यूरुलेंट इन्फेक्शन ऑफ सब एरिकिनॉइड स्पेस एंड मोस्ट कॉमनली इट इज कॉल्ड बाय स्ट्रेप्टोकोकस न्यूमोनियाe in neonates by streptococcus agalactiae and in elderly it is caused by listeria monocytogenes. So ये spread कैसे होगा? From person to person by droplets, kissing or cough or nasopharyngeal carriers or sneezing. Roots can be hematogenous spread by blood including blood vessels and choroid plexus, then subarachnoid space. Then direct spread from infected site like otitis media, mastoiditis and sinusitis and due to anatomical defect in CNS. So predisposing factors or risk factors could be age, most commonly in newborns, neonates, vaccination, presence of CSF shunts, breach in blood-brain barrier, alcoholism, diabetes, immunosuppression and splenectomy. So sign and symptom क्या होंगे? Then obviously fever and vomiting होगा, intense headache, altered consciousness, photophobia and 3 साइन हमें यहाँ पर देखने को मिलेंगे which is nuchal rigidity, Kernick sign and Brudzinski sign. So nuchal rigidity क्या होती है? It is mainly stiff neck. It is the pathognomic sign of meningeal irritation and is present when the neck will resist passive flexion. Neck में mainly stiffness होगी. Kernick sign is when the hip is flexed, there will be stiffness of hamstring and inability to straight the leg. तो मीन्स न्यूकल रिजिडिटी में नेक की स्टिफनेस होगी, कर्निक साइन में लेग स्ट्रेट नहीं हो पाएगी, हैमस्ट्रिंग्स में स्टिफनेस होगी एंड ब्रुड्जिंकी साइन में जब हम नेक को पैसिवली फ्लेक्स करेंगे तो दिस विल रिजल्ट इन फ्लेक्शन ऑफ नीज एंड हिप्स. नेक्स्ट इज बल्जिंग fontanelle in neonates and it is organism specific sign which is purple rash and it is seen in M. meningitis which is meningococcal meningitis and it leads to meningoencephalitis, decreased consciousness, seizures, stroke, increase intracranial pressure. So selective medium इसके लिए क्या होगा? Thier-Martin medium and New York City medium. अब इसको अगर हमें डिस्टिंग्विश करना हो कि मेनिंजाइटिस बैक्टीरियल या ट्यूबरकुलोस है या वायरस है तो सर्टेन यहाँ पे कुछ पॉइंट्स है लाइक CSF विच इज़ 50 to 100, CSF का प्रेशर 50 to 100 mm of Hg विच इज़ नॉर्मल. इन बैक्टीरियल इट इज़ हाई, ट्यूबरकुलोस मॉडरेटली एलिवेटेड एंड इन वायरल it is slightly elevated or normal. And similarly glucose which will be decrease less than 14 pyogenic, 20 to 14 tuberculous and normal in viral. क्यों? क्योंकि वायरस ग्लूकोज को यूटिलाइज नहीं करता. सेम फॉर प्रोटीन, मोर देन 45 in pyogenic, 100 to 500 in tuberculous and 20 to 80 in viral. Next is meningococcal meningitis which is caused by Neisseria meningitidis. So it is a gram-negative diplococci, lens shape और half moon shape. इस तरह की इसकी कुछ शेप होगी, adjacent sides इसकी flat होगी. Virulence factor will be capsular polysaccharide, outer membrane protein, LPS and endotoxin, lipopolysaccharide, IgA protease and adhesin. पैथोजेनेसिस सेम, या तो हेमाटोजेनिस, डायरेक्ट स्प्रेड, कंजक्टाइवा, olfactory nerve through cribriform plate. So clinical manifestations are rashes which are purple rashes जो अभी हमने देखा, septicemia, Waterhouse Friderichsen syndrome which include purpuric rash, DIC shock, multi-organ failure, pyogenic meningitis, chronic meningococemia, post meningococcal reactive disease. So drug of choice will be ceftriaxone and vaccine can be bivalent or quadrivalent. बाइवेलेंट में सेरोग्रुप A and C प्रेजेंट होंगे एंड क्वाड्रीवैलेंट में सेरोग्रुप A, C, Y एंड W135 प्रेजेंट होंगे. नेक्स्ट इज लिस्टेरियोसिस विच इज कॉज्ड बाय लिस्टेरिया मोनोसाइटोजेंस. सो ट्रांसमिटेड बाय कंटेमिनेटेड फूड और वर्टिकल ट्रांसमिशन. कॉमन फूड सोर्सेज आर रेडी टू ईट फूड, milk, soft cheese, uncooked hot dogs, so commonly found in stored food due to its inability to survive regeneration. Pathogenesis spread कैसे होगा? It will enter intestinal epithelium, survive inside the host cell, then host cell will cause actin polymerization. Bacteria will reach near the cell membrane and migrate to epithelial cell or macrophages by direct cell to cell spread, which is mediated by listeriopods. So in neonates it will show early onset or late onset. In pregnant women, for fetus it can cause abortion, preterm delivery, early onset disease, and in mother it can cause flu-like symptoms, bacteremia, meningitis or gastroenteritis. So treatment is PPI drugs, proton pump inhibitor, cotrimoxazole or amoxicillin. Next is tubercular meningitis, which is a result of hematogenous spread of primary or post-primary TB, tuberculosis. Features will be headache, malaise, low-grade fever, night sweats, anorexia, irritability, mental changes, confusion, lethargy, neck rigidity, altered sensorium, cranial nerve paresis, stroke or coma due to intracranial hypertension and hydrocephalus. So TLC will be up to 1000. There will be cobweb coagulum due to high fibrin content in the fluid. Gold standard test is CSF का culture, LJ medium till 4 to 8 weeks and MGIT till 2 to 3 weeks. CT MRI for hydrocephalus and abnormal enhancement of basal cisterns. This will show. Treatment is glucocorticoids to decrease the CSF. The next is Treponema pallidum, neurosyphilis, which is tertiary form of syphilis, which is STD also, sexually transmitted disease, and most of it is asymptomatic, 25 to 40% cases, meningeal syphilis, meningovascular syphilis, embolic stroke. Then it will show tabes dorsalis including ataxia, foot drop, paresthesia, bladder disturbance or impotence, and general paresis of insane जिसका न्यूमोनिक ही paresis है, personality defect, affect reflexes. Eye will show Argyll-Robertson pupil, altered sensorium, intellect, memory loss or speech. TLC will be greater than 5. Then treatment is aqueous crystalline or penicillin G. The next is viral meningitis, which is the second most common meningitis, most commonly caused by enterovirus, and others can be herpesvirus like herpes simplex, varicella zoster and EBV. Then it can be arbovirus by LCM, HIV, mumps, measles, influenza, and spread by close contact with infected people and in season of late spring to fall. Clinical manifestation वही सब होंगे, fever, vomiting, headache, stiff neck, photophobia, trouble in waking up from sleep and lack of appetite in babies. So CSF will reveal TLC from 25 to 500, glucose level normal होगा, protein normal या increase होगा and lymphocytes predominant होंगे. Gold standard will be molecular method PCR or real-time PCR. Treatment is acyclovir or oligoclonal gamma globulin bands. So next is Coxsackie virus, which has mainly two groups, A and B. A will show serotype 1 to 24 except 15, 18, 23 and B will show 1 to 6 serotype. Clinical manifestation will be atypical meningitis, herpangina, hand-foot-mouth syndrome, pleurodynia, which is also called epidemic myalgia or Bornholm disease, myocarditis, pericarditis, common cold, acute hemorrhagic conjunctivitis, pancreatitis or generalized disease of the infants. So group A and B both will show suckling mouth, intracerebral inoculation, but group A will show flaccid paralysis, generalized myositis, aseptic meningitis, conjunctivitis, AH conjunctivitis, acute hemorrhagic, herpangina and hand-foot-mouth disease, and group B will show spastic paralysis, focal myositis, aseptic meningitis, pleurodynia, myocarditis, pericarditis, hepatitis, pancreatitis, pneumonia and GDO of infant, general disease of infant. Next is parasitic disease of CNS. First is Naegleria fowleri, which causes primary amoebic meningoencephalitis. So it is a free living amoeba found in fresh water, mainly warm, pond, lake or river. दो फॉर्म में मिलेगा, अमीबॉइड एंड फ्लैजिलेटेड. अमीबॉइड नॉर्मली ह्यूमंस में मिलेगा एंड फ्लैजिलेटेड एनवायरनमेंट में. सो इट इज़ अ थिक स्मूथ डबल वॉल cyst. And pathogenesis is there will be nasal contamination with trophozoite during the swimming. It will enter nasal mucosa, cribriform plate, olfactory nerve and brain. So 20 micrometer is amoeboid trophozoite, lobular pseudopodia which is called lobopodia, granular cytoplasm, large central karyosome in the nucleus, and we will perform CT scan and MRI which will reveal obliteration of cistern, diffuse enhancement around midbrain, subacinoid space and cerebrum. Treatment is amphotericin B. So next is Acanthamoeba culbertsoni, और एक और species है Acanthamoeba castellani, which will cause GAE, granulomatous amoebic encephalitis in HIV infected people and corneal ulcer in contact lens user. Pathogenesis is inhalation of aerosol contaminated with cyst of trophozoite, then it will enter the lungs, then CNS by hematogenous route and finally cornea. So अब इसको Acanthamoeba क्यों कहा गया है? ड्यू टू थॉर्न और स्पाइन लाइक pseudopodia which is Acanthopodia, single nucleus with central karyosome and double walled cyst and outer wrinkled cyst wall. जो आउटर वॉल होगी वो नॉर्मली रिंकल्ड होगी. नेक्स्ट इज टॉक्सोप्लाज्मा एनसेफेलाइटिस विच इज कॉज्ड बाय टॉक्सोप्लाज्मा गोंडाई. इट इज ऑब्लिकेट इंट्रासेल्युलर पैरासाइट. दे विल बी क्रीजेंट शेप टेक्कीजॉइड और कोमा शेप्ड एंड क्रीजेंट शेप ब्रेडिजॉइड विच इज एसेक्सुअल फॉर्म्स. देन सेक्सुअल फॉर्म इज oocyte. Pathogenesis is that it affects HIV infected patient, elder patient and ingestion of uncooked cat. HLA-DQ3 जीन इज इन्वॉल्व. सो इसका लाइफ साइकिल क्या है? सबसे पहले इन्फेक्शन, देन एक्सिस्टेशन इन द इंटेस्टाइन. इंटेस्टाइन में एक्सिस्टेशन होगी, देन जिससे स्पोरोजॉइड और ब्रेडिजॉइड रिलीज होंगे. इट विल चेंज टू टेकिजॉइड, देन देयर विल बी एंडोडायोजेनी, देन mesenteric lymph node through it will enter extra intestinal organs, then bradyzoid, finally tissue cyst, and from there cat will acquire the infection. Then bradyzoids are released, again gametocyte formation, male and female gamete will form zygote, then sporulated oocyst which will cause infection. Definitive host is cat, intermediate host is man. Clinical manifestation is that in immunocompetent host it will cause lymphadenopathy and immunocompromised host it will cause encephalitis. And in congenital form it can cause chorioretinitis, hydrocephalus or intracranial calcification. And treatment is cotrimoxazole. The neurocysticercosis which is caused by Taenia solium, caused by larval stage of Taenia solium. It is of two types, parenchymal and extraparenchymal. Cysticercus cellulosa is oval, 5 mm long, yellowish white. It is two-chambered, bladder-like outer chamber, 0.5 ml of vesicular fluid, and inner chamber consists of growing scolex. Clinical manifestation: seizure, hydrocephalus, increased intracranial pressure, chronic meningitis, focal neurological defect, and dementia. Diagnostic criteria is modified Del-Bruto diagnostic criteria, and treatment is albendazole or praziquantel.